So this morning I'm going to introduce a new laser for opening the capsula. I'm really glad George did such a great introduction of the historical evolvement of this surgical step. I have been using femtosecond laser for over 5 years. I've done almost 10,000 femtosecond laser assisted cataract surgeries. It's a great tool, but why don't we all use it for all our surgeries? Well, it's hell expensive and it requires additional time. So that's why we seek for something which would be more cost effective, and this is one of the possible solutions. So I'm co-developing a new compact laser called CapsuLaser. Actually, the delivery system of this laser mounts underneath of existing microscope, and it fits all the current microscopes. The machinery is cost effective, does not alter patient flow. In fact, you would do your surgery about the same manner as you do with manual capsulorhexis, because that surgical step is pretty fast. So this is a side view of this CapsuLaser underneath of my old size microscope. We do have several microscopes. I also have Lumera, but this ancient microscope is actually my favorite one, and I do most of the surgeries here. The optic is huge. The reflex is from any angle, and I think this is the best microscope I ever had. Also, the service cost is very low. It runs and runs and runs, so I like it. Even the 3D 3D 4K cameras which are on the microscope are bigger than the laser, so that just tells us about the size of this laser system. So we perform a laser capsulotomy in about 1 second after everything is aligned and ready. We start inside, go 360 degrees around, and go inside again to conclude circular capsulotomy in every case. The capsulotomy performed by CapsuLaser showed a really high tear resistance at the lab. The lab tests were done in California, and the laser tissue interaction causes collagen phase change, which change the collagen into the amorphous structure, and also the edge curves, like you see in the right part of the picture, and that improves the tear resistance of this capsulotomy. You can center on visual axis of pupil. We have a blinking aiming beam there, so the patient can look at the aiming beam. The visibility of capsulotomy is significantly improved by blue stained edge, which is blue stained for about 24 hours. And the current CapsuLaser model comes with diameters of capsulotomy which you can set from 4.5 up to 6.5 millimeters in 0.1 millimeter steps. So as I have a heavy sore throat today, I will continue with the video with the narration, which is going to overview the current surgical techniques for capsulotomy and CapsuLaser.
A circular opening in the lens capsule is a gate inside the lens for cataract surgery. The most common way to open the capsule is a manual capsulorhexis. Handheld forceps are introduced through the main or side port incision to punch the capsule and create a circular opening in it. The shape is not always circular, and occasionally a capsulorhexis is either too small or larger than the IOL optic, which can compromise long-term IOL stability. Capsulotomy can be performed by laser with the promises of high precision. Current femtosecond lasers are bulky and expensive and usually require a dedicated operating room with strict air conditioning control and additional patient manipulation. Femtolasers require a firm connection between the eye and the laser, achieved by a process called docking. Femtolasers cut the capsule with high precision and produce so-called free-floating capsulotomies. But the cost and time are a burden, preventing a wider spread of this laser technology. We have developed a compact and cost-effective device called CapsuLaser, which is mounted under the surgical microscope and performs capsulotomy in 1 second. The capsulotomy procedure is fast, precise, and reliable. The capsular edge is very firm and elastic, and significantly more stretchable compared to manual capsular excess. CapsuLaser is a small device with a delivery system mounted under the surgical microscope. After the trypan blue was washed out, the anterior chamber is filled with OVD. We have used this device in over 50 eyes and obtained a complete circular capsulotomy in all cases. CapsuLaser capsulotomy can be used for innovative IOL fixation. The reliable, precise capsulotomy is important for long-term IOL centration. After the surgical contact lens was placed, capsulotomy was performed in 1 second. The central capsule was removed, followed by cataract removal. Blue staining improves the capsular edge visibility. We have used Femtis IOL, which is designed for optic fixation in the laser capsulotomy by means of dedicated microhaptics. The IOL was placed into the cartridge and ejected through a 2 mm microincision into the eye. The leading haptic was introduced straight in the capsular bag. The microhaptic at 6 o'clock was clipped on the capsule. Then the trailing haptic was introduced in the capsular bag. The capsulotomy edge is very firm due to the collagen phase change caused by the laser. The microhaptic at 12 o'clock was clipped on the capsule. Now the smaller microhaptics at 3 and 9 o'clock are being clipped too. The IOL optic is perfectly fixed into the capsular opening. This way, reliable IOL centration, which prevents the IOL rotation, was achieved. The patient was able to see 20/20 unaided with the right eye and 20/20 with -0.7.5 cylinder with the left eye. He is a professional truck driver who often drives at night. He does not refer any halos or glare at night whatsoever. The OCT image shows side port incisions, the IOL close behind the iris and distant from the posterior capsule. Here is the lens 3 months post-op. The circular capsulotomy holds the IOL safely in place. The microclips hold on to the capsulotomy edge with very little fibrosis. There are no signs of PCO. Laser capsulotomy serves as a perfect support for IOL centration. The ongoing studies are collecting more data with longer follow-up. CapsuLaser capsulotomy is a promising new way to perform laser capsulotomy and can make laser capsulotomy much more easily available worldwide. Thank you for your attention.
So that was a video about the procedure, and of course CapsuLaser is usually used for conventional IOLs implantation, but this was one of the interesting things which I just dare to share with you. So regarding the clinical studies, we performed the first feasibility study on 20 eyes with no laser-related complications. We today concluded CE mark study data gathering with 124 eyes. It was a control CR monitored study, which again shows laser precision and safety, and the data, I believe, was already submitted this month. And we run on top of that a series of complicated eyes. We have eyes after PKP, We cut the capsula through phakic IOL, which is also possible with CapsuLaser. It works very nicely on white intumescent cataracts too. Regarding the CMARC study, we had very homogeneous enrollment of those 124 eyes regarding the grade 1, 2, and 3, and regarding the age groups, and you see all those groups match pretty well, or almost perfectly. We had little more females in the CapsuLaser group, but both groups had 62 eyes. So the CapsuLaser diameter mean was 5 millimeter, right on target, manual 4.92 mean, standard deviation 50 microns on CapsuLaser group and 80 microns on the manual, and circularity 99 versus 96%. Here are a few pictures just documenting the precision and consistency of those laser capsulotomies, which were documented at the study. So this is the overall diameter chart, and we have more than 40% of eyes with capsulator exactly on 5 millimeters, and with 0.1 difference we have next 20 and 20%, so over 80% were within 0.1, and you see the yellow columns of the manual capsulorhexis are more spread, despite the surgeries were performed by 2 highly skilled and experienced surgeons who each of them performed over 2,000 manual cataract capsulorhexis every year. Distance corrected visual acuity not really different in both groups. So in conclusion, it looks like the CapsuLaser is a very promising new way of laser capsulotomy, which brings cost-effective laser precision, and that's, I believe, the main advantage of this approach. It does not alter patient flow, sounds appealing to patients. Today we have experience with over 300 eyes, and CMARC is being expected by the end of this year. Thank you for your attention.